Welcome back to my channel, guys. Today let's learn about compartment syndrome, which has been asked in NEET PG some 2 to 3 times. So if you just spend here for 5 minutes, you can solve question related to the compartment syndrome. Let's dive into the topic. So for definition, this is a surgical emergency which is caused by increase in pressure within a closed osteophyseal compartment, and that causes decrease in perfusion, that causes muscle and nerve ischemia, and this causes irreversible damage. I think most of you might not understand this, so let's get into the pathophysiology of this thing. So there is intracompartmental pressure increase in compartment mein there is pressure is increasing, so that decreases capillary perfusion. So when the capillary perfusion is decreased, that automatically decreases oxygen delivery to the muscle and nerves, so that causes inflammatory response. So what happens? So that will be muscle edema, and because of this the swelling happens, size increases, so there will be further increase in compartment ka pressure. So this is what is happening here. So if this compartment syndrome is untreated, so that will cause persistent ischemia. The muscles don't get oxygen supply for most of the time, so that causes muscle necrosis and nerve damage. Iska blood supply in aorta, so it happens necrosis and damage, that causes fibrosis, and that causes Volkmann ischemic contracture. So this is the pathophysiology. Just simply think like your hand, there is anterior compartment, there is compartmental pressure increases. That may be due to fractures or soft tissue injuries, anything. So compartment ka pressure increase ho rahe. When that is increasing, capillary perfusion is decreasing, so that causes decrease in oxygen delivery, muscle edema, further there is increase in compartment pressure. So what are the clinical features so that you can identify a compartment syndrome are? There is a pain on passive stretch. This will be most commonly asked in the questions. And puffiness or tense swelling. And there are 5 P's you need to remember in compartment syndrome: pain on passive stretch, puffiness may be there, pallor, paresthesia, pulselessness, and paralysis. These pulselessness is a late sign basically, so you have to remember the 5 P's in the compartment syndrome. Pulses may be normal in early stages because large vessels are usually not compressed initially. That's the reason the pulselessness is a late sign. Coming, the common fractures which are associated with compartment syndrome are tibial shaft fractures, distal radius fractures, and forearm fractures. So these are the common fractures associated with. And now let's come into what are the risk factors. The risk factors are high energy trauma, tight gas, vascular injuries, perfusion injury, prolonged compression, intoxication, burns. These might not be asked in your questions, risk factors, but just remember it. And the most commonly asked here is investigations. What is that? Compartmental pressure measurement. So using the manometer. So if the compartmental pressure is more than 30 mmHg, then that is diagnostic of compartment syndrome. And there is something called differential compartment pressure. That simply means diastolic blood pressure minus compartment pressure. If it is less than 30 mmHg, then fasciotomy is indicated. So let's see treatment. Treatment mein what do? You have to do emergency fasciotomy. This is what you have to do. So what is the goal here? Decompress the compartment, and lower the pressure and restore the perfusion, prevent irreversible muscle and nerve damage. These are your goals. You have to decompress it. So first, do you give a longitudinal incision over the skin, and then you have to incise the superficial and deep fascia through the length and allow the muscles to bulge out. You have to allow them to bulge out so that pressure falls. When the pressure falls, you have to make sure vascularity is improved and perfusion be होना चाहिए. So this is what you have to make sure. This procedure is emergency fasciotomy. Fine. So wound management, how do you do? Vacuum or negative pressure therapy, delayed primary closure, or skin graft. So the key takeaway here is, if you think of compartment syndrome in any patient with severe pain, the pain will be out of the proportion and there will be tense swelling and pain on passive stretch. You have to, act emergently, like you shouldn't wait, and you have to decompress as soon as possible. If there is delay in treatment, that may cause irreversible muscle necrosis, Volkmann ischemic contracture, loss of limb. Now let's see if you can solve the questions related to this topic, which are almost similar to NEET PG ka questions. Now let's see the questions. A 25-year-old man sustains a closed fracture of tibial shaft. 4 hours later, he complains of severe pain that is disproportionate to the injury and worsens on passive stretching. And you see, distal pulses are palpable. What is the most likely diagnosis? You can see the options here. So, whenever there is a disproportionate to the injury and worsens on passive stretching, and the distal pulses are palpable. Distal pulses are palpable because you can see pulselessness is a late sign, because that's not affected the first. Distal things are not affected first. That's the reason it is palpable only. So, what is the diagnosis here? It's acute compartment syndrome. Fine. Now, let's go to another question. Which of the following is the earliest clinical sign of acute compartment syndrome? This question, see, pulselessness is a late sign, and paralysis is also the late sign, and pallor also little. I can't say it as late, but the earliest I'll be telling you, it is pain out of proportion to the injury, which is increased by passive stretch. So this should be your earliest clinical sign, and this should be your answer. A 20-year-old man has sustained a high-energy fracture of the tibia. 6 hours later, he develops severe pain on the leg, which is not relieved by analgesics. On passive dorsiflexion of the toes, the pain is increasing. The leg is tense and swollen, but dorsalis pedis pulse is palpable. So, by these features, you can clearly see this is acute compartment syndrome. So, what will be the management of acute compartment syndrome? That will be, as you have seen in the video, that will be urgent fasciotomy, will be a immediate management. Next question. A 22-year-old man sustains a fracture of the radius in a road traffic accident. After 5 hours, he complains of severe pain in the forearm that is not relieved by analgesics, and it increases on passive stretching on the fingers. The forearm appears tense and swollen, but radial pulse is palpable. Sensation and motor power are normal at this stage. Which of the following is underlying pathophysiological mechanism of this condition? So you can see all these questions are saying same things, that you should diagnose it as acute compartment syndrome, but they are leveling up, like what management do you see and what are the pathophysiology involved here. So you can see the options are venous thrombosis leading to arterial occlusion, increased intracompartmental pressure causing decreased capillary perfusion, and there is arterial spasm causing complete cessation of blood flow, and option D is lymphatic obstruction leading to reduced arterial inflow. So whoever have listened to the concept which I said earlier in this video will definitely know the answer, that will be increased intracompartmental pressure. So guys, if you find this video helpful, please like, subscribe and share it to your friends who are preparing for NEET PG. I'll come back with more videos. Thank you for watching.